Good morning, everybody. My name is Aman Chauhan. I'm one of the medical oncologists at University of Miami. I lead our neuroendocrine cancer program at Sylvester Comprehensive Cancer Center, and I also co-lead our theranostics drug development program at University of Miami. I would like to thank LACNETS for giving me the opportunity to talk at their national symposium. And today I would be discussing NETS 101. I think this is a very important topic to set the stage for the remaining lectures for the rest of the day. Today you would be hearing some of my colleagues and some stellar NET experts from across the country. But my goal here is to acquaint you with the journal terminology of neuroendocrine cancer. How do we go about classifying? I would basically approach this topic the way I approach my patients in my NET clinic. So let's get started. Neuroendocrine cancers are rare tumors. In this figure, what I'm trying to showcase is the incidence of neuroendocrine cancer as compared to other cancers. Fortunately, most of the solid tumors, breast cancer, colon cancer, lung cancer, the incidence, that means the newly diagnosed cases every year, they have remained steady. If at all, their incidence has reduced in the last few years. However, what is concerning is the line in the bottom, the yellow line. We have seen 7 to 8-fold increase in the incidence of neuroendocrine cancers in the same time period. It is quite concerning. What is even more concerning is the prevalence of neuroendocrine cancer. These are cumulative cases over the years with the diagnosis of neuroendocrine cancers. And as you can see in the figure here, neuroendocrine neoplasms of GI origin are now the second most prevalent cancer of GI tract after colorectal cancer. We are talking more than gastric, esophageal, hepatobiliary, and pancreatic cancer. So the overall burden of this disease is growing tremendously, both in the United States and globally, which really puts the focus back on this cancer. And we need to really improve the way we manage these cases, the diagnosis, and the treatments. Whenever I see a neuroendocrine cancer patient in my clinic, especially a newly diagnosed patient, I like to go over some of the critical aspects of the diagnosis, and these are listed in front of you. I like to know where is the primary site of the tumor. I like to know the grade and morphology of the tumor, the stage, what is the functional status, and what is the somatostatin receptor status. And in this talk, we will go over each of these critical elements, and I want you to ask these questions from your oncologist. So let's discuss about primary site. And that's true for any cancer. Whenever a patient is diagnosed with a tumor or neoplasm or a cancer, the first step is, where is the cancer originating from? Neuroendocrine cancers can originate from anywhere in the body, but by far the three commonest locations are small bowel, second is pancreatic NETs, and third is lung. However, it's not uncommon for NET specialists to see neuroendocrine tumor of prostate, gallbladder, ovaries, breast, head and neck region. So it's very important for us to know what's the primary site of the tumor. Sometimes knowing that information can help us expand our treatment options for that site-specific tumor. Once we know the primary site of the neuroendocrine tumor, the next step is to know the grade and morphology. I would like to spend some time here because this is by far the most important step in the diagnosis. If we get the grade and morphology wrong, we will get the subsequent diagnostics and therapy options wrong. So let's go over some of the broad categories of neuroendocrine cancers. When I have a patient, I first like to classify a patient into two broad categories. Is it a neuroendocrine tumor patient or NET patient, or is it a neuroendocrine carcinoma or NEC patient? NET patients are also called well differentiated, and we will discuss in next couple of slides what does that mean. The NEC patients are also called poorly differentiated neuroendocrine carcinomas. Sometimes you would see in pathology report that it says small cell or large cell neuroendocrine carcinomas. These are further subtypes of poorly differentiated neuroendocrine carcinomas. This is our first stop, and we really need to make sure that we are dealing with NAC or NET, because if we mix these, we're going to get the diagnosis wrong and the treatment options would be absolutely wrong. Now, once we have figured that out, there are different types of neuroendocrine tumors, NET, based on their grade. It could be grade 1, grade 2, grade 3. NECs, on the other hand, are by definition all grade 3. So they're all very aggressive tumors. Now, neuroendocrine tumors or neuroendocrine cancers of lungs are described in somewhat different way. Although they imply the same meaning, the terminologies might be a little bit confusing. As compared to NET versus NEC, the spectrum of neuroendocrine neoplasms of the lung spreads across from the lowest grade called typical carcinoid to intermediate grade called atypical carcinoid, and the highest grade called small cell lung cancer or large cell neuroendocrine cancer, or otherwise called poorly differentiated neuroendocrine carcinoma. They are both trying to say the same thing, but in different terminology. So please don't get confused if you come across these terms. We are sticking with the term carcinoids for lung mets. However, the GI neuroendocrine tumors, they prefer to call it well-differentiated versus poorly differentiated, and then the subsequent subtypes, as we mentioned before, grade 1, 2, and 3. Now let's talk a little bit about morphology. Remember, I told you the most important thing is grade and morphology. So what do we mean by morphology? Morphology literally means the look of the cancer. So when we look the cancer cells under the microscope, this is what we see. We are seeing a sample of neuroendocrine tumor, NET. And the way it looks, the glandular pattern, of course, me and you might not be able to evaluate that, but a astute pathologist would know that this is an NET. And on the center of the slides, what you're seeing here is a special stain called Ki67. Ki67 stains the tumor cells brown. As you can see, most of the slides bluish, but then you see some brown spots. This is signifying low uptake of Ki67 in these cells. So these are low grade or low Ki67 well-differentiated NET. As contrast to poorly differentiated NECs. Now those cells, as you can see, they lose all the typical neuroendocrine glandular and other typical pattern. These are just the sheets of cell dividing uncontrollably. So that's the morphology, and it can be either small cell, as you can see here on the slide, small round blue cells versus large cells. And on the center, what we see here is the Ki67. As contrast to the previous slide, you can see a lot more brown stain here. That means the Ki67 is very high. So poorly differentiated neuroendocrine cancers or carcinomas, they're by definition grade 3. That means the Ki67 is always more than 20%. And routinely for small cell and large cells, they're above 50%. Sometimes for small cells, are routinely over 80 to 90%. Now, why is it important for us to understand these different grades and different morphology? So these are the survival outcome of different types of neuroendocrine cancers. The line on the top is showing the survival in low and intermediate. That means grade 1 and grade 2 well-differentiated NETs. And as you can see, we are talking about overall survival in several months. These are spanning across years and decades. As compared to the blue line, which signifies the grade 3 well-differentiated NET. So higher grade well-differentiated NET, which does, with more aggressive cancer, and the outcome is unfortunately poorer as compared to grade 1 and grade 2 well-differentiated NET. The last group in the red line is showing the outcomes in poorly differentiated NEC. This is the subtype that we initially described could be small cell or large cell. And unfortunately, this is the cancer which has the worst outcome of all of the different subtype of neuroendocrine cancers, with a median survival in 1 to 2 year range and 5 year survival less than 5%. And this is precisely the reason why we need to know different subtypes so that we can attack different subtypes of tumor with different tools. We will often use cytotoxic chemo for the very aggressive disease versus maybe hormone therapy for indolent disease like sandostatin or lanreotide. And based on these survival outcomes and our knowledge of pathology, grading, morphology, the WHO classified neuroendocrine tumors into NETs, the well-differentiated, versus NECs, the poorly differentiated. And NETs, as I mentioned, are three different flavors of it. So under 3% grade 1, 3 to 20% grade 2, more than 20% grade 3. And as I mentioned before, the NEC are by definition always grade 3, so more than 20%. There's also another way to classify it. It's called mitotic index, and I've mentioned it here. So a pathologist can use either or both of these tools to grade the tumors. Now we have figured out where's the primary site, what's the grade and the morphology of neuroendocrine tumors. The third and most important part of the diagnostic process is the stage of cancer. What do we mean by stage? Now, stage is not unique for just neuroendocrine tumor. If a patient is diagnosed with any cancer, you want to know the stage. And stage basically tells us the extent of cancer in our body. So primarily, there are 4 stages of cancer. Stage 1 of cancer means that cancer has not yet spread. So if I'm talking about a cancer of pancreas, it is still within the pancreas. Stage 2 and 3 cancer implies that cancer is still early but has had local spread. Maybe the local lymph nodes are involved. And stage 4 cancer means the cancer has already spread and has invaded a different organ. For example, neuroendocrine tumors like to go to bones, liver, and distant lymph nodes. So that would imply the patient has stage 4 cancer if it has spread to liver or bone or other organ. And why is it important for us to know the stage? Because the treatment would be dictated by the stage. An early stage cancer can potentially be cured with help of surgery, sometimes chemo and radiation. Stage 4 cancer, by definition, is not curable, so we cannot cure it. However, we certainly have good treatment options to control it so that we can prolong patients' life and improve quality of life. So staging is very critical in developing those early treatment plans. How do we come about staging? How do we uncover the extent of disease? It's with the help of diagnostic imaging. We might use CT scans, MRIs, and PET scans. The PET scan could be FDG PET for high-grade cancers or DOTA PETs for low-grade cancers. Later today, you would hear from some of our radiologists regarding the role of different scans in management of neuroendocrine cancers. Besides the scans, sometimes we need to do certain procedures like endoscopies, colonoscopies, and mediastinoscopies to further categorize the staging. Is it early stage or it is advanced, and to get the lymph node status in that particular organ. Now, the final 2 steps before we conclude our talk. Neuroendocrine tumors are very unique in the sense because some neuroendocrine cancer patients can secrete a hormone, and that hormone can give rise to certain symptoms. So it's really important to know the functional status of neuroendocrine cancer patient. What do I mean by that? If a patient is able to secrete a hormone, which is giving rise to certain symptoms, then we call that as a functional neuroendocrine tumor. On the contrary, if the patient is not secreting any hormone, then the patient is classified as a non-functional neuroendocrine tumor. So let's talk a little bit about that. You've often heard neuroendocrine cancer patients are often misdiagnosed or there's delay in diagnosis because the symptoms are so vague. Patient can present with flushing, diarrhea, sweating, wheezing, heart problems, and these are common symptoms seen in a lot of other medical disorders. So why do these symptoms happen in some, not all, but some NET patients? This happens because some NET patients can secrete these hormones. I've listed some of them for you here: serotonin, insulin, VIP, glucagon, ghrelin, somatostatin, ACTH, gastrin. And there are more. Some we might not even have yet discovered. However, if a patient is secreting these hormones, their elevation can give rise to certain specific symptoms. Let's take an example of serotonin. That's by far the commonest functional neuroendocrine tumor. And excess serotonin can give rise to all these symptoms that are listed here. Flushing being the commonest, but it can give you diarrhea, carcinoid heart disease, cramps, leg swelling, wheezing, and you can see it. So it's really important to understand the functional status of neuroendocrine tumor, and these can be not only detrimental for overall outcome, but significant impact the quality of life of patient. It also helps us manage the patient better because if somebody is producing excess amount of serotonin, there are ways that we can block that. Here is the flow chart. I can show you the manufacture and secretion of serotonin. As you can see here, tryptophan, an essential amino acid that we eat in our diet, gets converted into 5-HT, that is serotonin, and gets stored in the tumor cells. The tumor cells then release it intermittently, and the release of serotonin causes that flushing and diarrhea and other symptoms. However, we have opportunity to slow down the release by blocking the somatostatin receptor with help of somatostatin analog. And you know two of them, lanreotide and sandostatin. So that's how these drugs work. They block this receptor, so reduce the secretion of serotonin, and patients have improvement in their carcinoid syndrome symptoms. On the other hand, we also have a newer drug called teletostrate ethyl, or Zermelo, which goes to the root cause of the problem and tries to block the conversion of tryptophan into 5-hydroxytryptamine, and in turn reduces the secretion of serotonin. So understanding the functional status gives us additional insight into the tumor biology and ways to how to help the patient. So here I'm putting under the lens the role of somatostatin analog and the role of Zermelo in controlling carcinoid syndrome. And Zermelo, as I mentioned, has been shown in the studies to lower the urinary 5-HIA, which is a breakdown product of serotonin, and this in turn helps in the carcinoid diarrhea. So coming on to the last leg, we've now understood a lot of different facets of diagnosis. And the last facet is somatostatin receptor status. Now, neuroendocrine tumors are also unique because they tend to have somatostatin receptors on their surface. Now, why do we need to know them and how does it help us? If we can detect somatostatin receptors on tumors, we can essentially develop a tool to accurately locate where the tumors are. And that's exactly what we've done over the years. So back in the days, there used to be a scan called octreoscan. Now we have much more sensitive and superior scan like NetSpot or gallium-68 dotatate, or recently approved copper dotatate scan called DetectNet. And as you can see here, because we are able to target somatostatin receptor with the help of somatostatin analog, which is radio labeled, we can actually see these tumors, locations, precise burden of the disease. And this really helps us in understanding the burden, the quantum of disease in the body. More importantly, we also have ways to target these somatostatin receptors, not just for diagnosis, but also for therapy. And we call this peptide receptor radionuclide therapy. Now, you've heard of this drug called Lutathera. This is the first FDA-approved theranostics PRRT drug approved for progressive gastroenteropancreatic, that means neuroendocrine tumor of GI tract and pancreas in the United States. And this works very well. I'm giving you a real-life example from a patient of mine where you can see the NetSpot scan showing innumerable tumors in the bone, in the liver, and the patient got 4 doses of Lutathera, the PRRT drug, and there was 63% reduction in the total tumor binding index, but more importantly, significant improvement in quality of life for patient. So that's why it's important to know somatostatin receptors, because if this patient did not have somatostatin receptor, this patient would have not qualified for this PRRT drug. So that helps us. And here is a schema of my previous institution from the Neuroendocrine Tumor Board. And as you can see here, these somatostatin receptor imaging, both gallium scan and now the latest copper DetectNet scan, is very important and helps us make a good decision when we discuss case in a dedicated Neuroendocrine Tumor Board. So right off the bat, when you talk to your oncologist, you need to understand your diagnosis. Are we dealing with NET or NEC? What type of NET, grade 1, 2, and 3? And we now know that this is based on the Ki67. So you need to ask your oncologist, what's my Ki67? If we are dealing with NEC, we know that this is a high grade. That means Ki67 will always above 20%. But we need to know, is it small cell or large cell, or is it difficult to interpret? We have made a lot of progress in neuroendocrine cancer in our field over the last 5 to 10 years. And as you can see, that we are adding new drugs every few years, and there are more in the pipeline. However, we need to do better. We need to do better for our patients because I told you we have over 170,000 patients who are diagnosed with neuroendocrine cancers in the US alone, and this patient population is growing. So clinical trials is the key step which will help us or enable us to develop new treatments and better treatments for our patient. Dr. Simran Singh would be talking about clinical trials later in detail. However, I wanted to finish my talk stating the importance of clinical trial and asking your oncologist after the diagnosis and the management plan, Doc, what clinical trials am I eligible for? What clinical trials are available in my region? Because they can certainly form an important part of your management process. With that, I would like to again summarize. When you go see your doctor, ask them the primary site, grading, morphology, stage of your tumor, functional status, and somatostatin receptor status. If you know this information, as you can remember, you would know exactly the next steps. What else needs to be done in terms of diagnostics? What else needs to be done in terms of starting therapies? Because these are the key aspects of what will dictate the management. With that, I would like to thank you for listening in, and till we meet again.